The last few sketches focused on bleeding disorders. So it's time to turn that frown upside down and dive into a few conditions that cause blood to be abnormally clotty instead. Thrombosis syndromes can be divided into acquired and hereditary causes. And in this scene, we're going to start with one of the most common acquired causes, antiphospholipid syndrome. Antiphospholipid syndrome represents a heterogeneous group of mechanisms that all end in the same result, clot formation. So around this POW camp, we've scattered a few thrombotic bunches of sticks, being used as cover for a few escapees. The classic manifestations of antiphospholipid syndrome include pathologic thrombosis in the venous and arterial system, as well as recurrent pregnancy loss. What sets this disorder apart from the other thrombotic syndromes, however, is the presence of antiphospholipid antibodies in circulation. Now, in this sketch, we've symbolized these antibodies at the top of the guard wall. See those antibody-shaped supports attached to that barbed wire? Also, if you look closely, within the wire are phospholipid shapes. Kinda like the phospholipids seen in lipid bilayers, actually. The term antiphospholipid, however, is a bit of a misnomer. In reality, autoantibodies target not only cardiolipin, a phospholipid found in mitochondrial membranes, but also a variety of other proteins with crucial functions in the regulation of blood coagulation and fibrinolysis. Antiphospholipid syndrome often develops secondary to some other autoimmune conditions. This is called secondary antiphospholipid syndrome. A few of the more common associated conditions are embodied by the guard here, hunting down the escaped prisoners. Let's see here. We've got rheumatoid arthritis, symbolized by that inflamed bone lantern. That white wizard hat is our recurring symbol for HIV. The evil white wizard from Sketchy Farm. And lastly, we've brought back our lupus wolf, representing systemic lupus erythematosus. Contrast this with primary antiphospholipid syndrome, when antiphospholipid antibodies develop in the absence of any other autoimmune condition. Weird, right? We don't really know the pathogenesis of antiphospholipid syndrome, but the most commonly accepted explanation is that antiphospholipid antibodies develop in susceptible individuals following exposure to either some kind of autoimmune condition or just due to genetic predisposition. Interestingly, once antiphospholipid antibodies are present, a second hit is required for development of full-blown antiphospholipid syndrome. Some proposed second hits include smoking, prolonged immobilization, pregnancy, oral contraceptive or estrogen replacement therapy, or cancer. Now, remember when I said that there's a whole potpourri of antibodies floating around in the circulation, targeting multiple phospholipids and proteins? We're just going to keep it simple and focus on the three most common autoantibodies: anticardiolipin, lupus anticoagulant, and anti-beta-2 glycoprotein. Starting with anticardiolipin antibodies, symbolized by that antibody arrow right to the heart. It turns out that anticardiolipin antibodies also react with the substance used in the RPR and VDRL tests for syphilis, resulting in false positives. What? Way back in Sketchy Micro, these tests were represented with a telescope, used to view the Treponema spiral galaxy. Kinda like a screening test used to spot Treponema pallidum. That pesky spirochete. This interaction with anticardiolipin antibodies is such a common phenomenon that recurrently positive syphilis tests on a question stem should immediately raise your suspicion for antiphospholipid syndrome. Another interesting antibody that pops up is called lupus anticoagulant. I know what you're thinking. Anticoagulant? But this is a thrombosis syndrome. Go back to your shanty. Okay, first of all, a first-floor studio apartment in Los Angeles right up against the 405 freeway shared with Dave, my creepy middle-aged landlord I found on Craigslist, does not qualify as a shanty. Secondly, lupus anticoagulant promotes clotting in the body, yes, but paradoxically, it seems to inhibit clotting when tested in the lab. As a result, when the blood labs come back, the activated partial thromboplastin time, or APTT, will be prolonged, symbolized by that prolonged noise caused by the woodpecker. Recall that a prolonged APTT was seen in both von Willebrand disease and hemophilia, two bleeding disorders. Don't be duped, though. All antiphospholipid antibodies, including lupus anticoagulant, have the ability to cause thrombosis via activation of phospholipid-dependent coagulation pathways, leading to widespread thrombus formation anywhere in the circulatory system. The last commonly tested antibody is the anti-beta-2 glycoprotein antibody, which we'll represent with a few antibody arrows attached to these glycoprotein-esque vines dangling from the wall, just like glycoproteins dangling from the cell surface. The presence of anti-beta-2 glycoprotein antibodies is most strongly associated with actually developing antiphospholipid syndrome, actual clinical thrombotic events, that is. Speaking of which, it's important to remember that the presence of antiphospholipid antibodies is not enough to diagnose antiphospholipid syndrome. 10 to 15% of patients who test positive for antiphospholipid antibodies never actually develop symptoms. That's why the diagnostic criteria for antiphospholipid syndrome include both laboratory confirmation of antiphospholipid antibodies and symptoms of thrombosis. The classic presentation of antiphospholipid syndrome consists of venous or arterial thromboses in a young patient with no known risk factors for hypercoagulability. Venous complications include DVT with or without concomitant pulmonary embolism, as depicted by the mass of thrombotic sticks in the iliofemoral river underneath our recurring symbol for PE. A nest thrombus cutting off circulation in a branch of the pulmonary tree. Arterial complications include TIA and ischemic stroke. Hence the black stroke we've incorporated into the helmet of our next escaping soldier. Antiphospholipid syndrome also affects the coronary arteries, leading to thromboses and an increased risk of coronary atherosclerosis. This can precipitate cardiovascular events, like MI, which we always symbolize with a broken heart string. Antiphospholipid syndrome can also cause vegetations to develop on heart valves, a phenomenon known as non-bacterial thrombotic endocarditis. And for endocarditis, we always show a flame from within the heart, like on these lanterns. As the name implies, these vegetations are non-bacterial. In other words, they're not caused by infection, but by damage to the endothelium of the valves with subsequent complement activation and platelet deposition on the valve itself. While they're not infectious, they can break off and get stuck somewhere else, causing PE or systemic thromboemboli. Interestingly, antiphospholipid syndrome tends to disproportionately affect women in a manner similar to the tendency for females to develop lupus and other autoimmune diseases. In women, watch out for pregnancy-related complications, such as multiple unexplained miscarriages and severe preeclampsia. The mechanism behind this is not well understood, but thought to be related to microthrombi formation within the placenta, cutting off nutrient and oxygen delivery to the fetus. Multiple miscarriages is a classic clinical scenario that you'll see on the test, so remember that empty carriage. All right, while the guards are distracted by that prolonged APTT, let's quickly review a few other acquired thrombosis syndromes before moving on to the hereditary thrombosis syndromes, which are admittedly more fun. Next up is a deficiency of either vitamin B6, B9, or B12, which can lead to a pathologic hypercoagulable state. In this sketch, we'll highlight B12 specifically, symbolized as usual by the cobalamin cobalt blue firework. We chose a firework because vitamin B12 deficiency results in a megaloblastic anemia because of decreased DNA production. This time, however, it's not a lack of something we're worried about. It's too much of something. Homocysteine, to be exact, symbolized by the homocysteine homing beacon. Looks like he's hot on the escapee's trail. Vitamin B6, B9, and B12 are all involved in the metabolism of homocysteine into other amino acids. Therefore, deficiency of any of these vitamins will result in elevated homocysteine levels, also called hyperhomocysteinemia. Turns out that too much homocysteine in the serum increases the risk of atherosclerosis and venous thromboembolism. Homocysteine does this by increasing tissue factor expression, enhancing platelet activity, and increasing thrombin formation, all of which lead to a hypercoagulable state. It's also classically associated with an increased risk of both cerebrovascular and cardiovascular events, though some of the data is conflicting. Check out our macrocytic wrestling sketch for way more info on B9 and B12 deficiency. All right, the next disorder in our list of hypercoagulable syndromes is pretty straightforward. What if the blood is just too thick? Hyperviscosity syndrome is a clinical presentation caused by a number of pathologies, all of which result in the blood being a lot, well, sludgier than normal. If you didn't totally block out physiology from your memory, you might remember that resistance to blood flow is directly proportional to viscosity. In other words, the higher the viscosity, the higher the resistance. Increased resistance to flow leads to blood stasis, perfect conditions for thrombus formation. Let's go over a few of the most common causes of hyperviscosity, starting with the prototypical hyperviscosity disorder, polycythemia. Polycythemia is generally defined as an increased number of red blood cells. So we've populated this muddy stream with an overabundance of red lily pads. Polycythemia is not a diagnosis per se, but a group of pathologies ranging from primary polycythemia, aka polycythemia vera, to polycythemia secondary to myeloproliferative diseases. While it may seem benign or even beneficial to have a little extra of the red stuff, polycythemia can actually cause some serious problems, which we'll cover in our polycythemia sketch. Hyperviscosity may also be caused by high levels of protein in the blood, which is the case in both multiple myeloma and Waldenstrom's macroglobulinemia. Both of these malignancies produce tons of excess immunoglobulins that clog up the plasma and make the blood more viscous. Though sickle cell disease is typically associated with lower than normal hematocrit, hence the anemia in sickle cell anemia, this condition can cause hyperviscosity syndrome due to the abnormal shape of the affected red blood cells. Their rigid sickle-shaped conformation causes them to get stuck in small arterioles and capillaries, leading to stasis and thrombus formation, which lead to what's called sickle crisis. For a more detailed discussion, go take a ride across the river Styx in our normocytic anemia chapter. Just like in antiphospholipid syndrome, patients with hyperviscosity syndrome will present with symptoms of arterial and venous thrombosis, such as heart attacks and strokes on the arterial side, as well as DVTs and pulmonary emboli, due to venous clots. Some interesting features of hyperviscosity syndrome include blurred vision, neurologic symptoms, and confusion. Just imagine all that thick blood gunking up the ocular and cerebral vessels. Well, that's it for the acquired thrombotic syndromes. Let's move on to the hereditary etiologies, a group of really interesting disorders, led by Factor V Leiden, the most common hereditary cause of hypercoagulability. Factor V Leiden ain't your grandma's Factor V, which normally activates Factor X, which in turn activates thrombin. This Factor V is mutated. See those Roman numeral 5s incorporated into the bear trap? Watch your step. Factor V Leiden is an autosomal dominant disorder that occurs mostly in younger Caucasians and accounts for nearly half of all hereditary thrombosis syndromes. Normally, protein C is responsible for cleaving and inactivating Factor V. At Sketchy, C is for captain. If the coagulation factors are fighters, think of protein C as their captain, telling them to stand down, controlling the whole clotting process so that it doesn't get out of hand. Well, in patients with Factor V Leiden, a single point mutation eliminates the usual spot where protein C can bind. So, Factor V can't be destroyed, causing coagulation as it goes. This is illustrated by the protein C captain here. Try as he might, he just can't deactivate this Factor V trap. To make things worse, inactivated Factor V normally has a negative feedback effect on thrombin after being cleaved by protein C. Therefore, the inability of protein C to cleave Factor V Leiden, colloquially known as protein C resistance, results not only in unchecked generation of thrombin, but also loss of the negative feedback loop that's supposed to inhibit even more thrombin formation. At Sketchy, thrombin is represented by a thrombeaver building a fibrin dam and clogging up the flow. So take a look in the back. Lots of thrombin activity due to an overload of Factor V activity means a big fat dam obstructing that iliofemoral river. By far the most common clinical consequence of Factor V Leiden is an increased risk of venous thromboembolism, such as DVT. If you're a heterozygote for the mutated Factor V, your risk of venous clots is about 5 to 10 times higher than normal. Individuals who are homozygous for Factor V Leiden, however, can have up to a 100-fold increased risk for blood clots. Over a lifetime, this means about 5% of patients will develop a venous thrombus, unless you start piling on the other independent risk factors for hypercoagulability. This includes pregnancy and OCP use, smoking, and prolonged immobilization, such as after surgery or long car or plane rides. So we've made him smoking, added an OCP design to his captain's hat, and immobilization? Well, nothing conveys prolonged immobility quite like a leg caught in a bear trap. Been there. For our next disorder, instead of Factor V, we're going to mutate the prothrombin gene. Prothrombin is the precursor to thrombin, which catalyzes the conversion of fibrinogen to fibrin, the critical final step in forming a fibrin clot. Thrombin also activates platelets as well as factors 5, 8, and 13. It pretty much does everything. As I mentioned earlier, at Sketchy, we symbolize thrombin with a throm beaver building a fibrin dam. Prothrombin, then, is a precursor baby beaver. Duh. Prothrombin gene mutation is the second most common inherited thrombophilia after factor V Leiden. And just like before, this disorder is inherited in an autosomal dominant fashion and is most often found in young Caucasians. Called prothrombin G20210A, is caused by a substitution of adenine for guanine in the prothrombin gene. Name makes sense now, right? G stands for guanine, A for adenine, and 20210 for, the zip code of Luke Perry's home in Beverly Hills, if I'm not mistaken. Because of this abnormal prothrombin gene, you start making more prothrombin than normal. That's why we've drawn in a whole family of baby thrombivores. This leads to a fourfold increase in the risk of thromboembolic events, such as deep vein thrombosis causing pulmonary embolism. As with factor V Leiden, this generally doesn't lead to a lot of clot formation. The risk only significantly rises when this gene mutation is combined with other risk factors for hypercoagulability. All right, our next thrombotic disorder involves protein C and S, embodied by our recurring protein C captain and protein S sergeant. Protein C is a naturally occurring anticoagulant protein in the body. Normally, after it gets activated, it combines with protein S, and the resulting protein C and S complex is responsible for inactivating activated factors 5 and 8, thereby suppressing the coagulation cascade. Now, we're talking clotting here, not bleeding. So our next disorder involves inactivating mutations of protein C and S. This is called protein C and protein S deficiency, respectively, symbolized by the captain and sergeant here, under the cover of that huge thrombus. Both protein C and S deficiency are inherited in an autosomal dominant fashion. So again, all the action is taking place in front of that autosomal dominant domino wall. Deficiency of either protein C or S will lead to increased activity of factors 5A and 8A, hence the number 5 hand signal and number 8 binoculars. More factor 5 and 8 means increased thrombin generation and an overall hypercoagulable state. This includes an increased risk of venous thromboembolic events, such as deep vein thrombosis with pulmonary embolism. Just like with factor V Leiden and that wacky prothrombin mutation, however, the risk only becomes significant when combined with other independent risk factors for blood clots like smoking and pregnancy. Treatment for a DVT in these patients is mostly identical to that of the general population, with one important exception: no warfarin for anticoagulation. Why, you ask? Recall from Sketchy Farm that warfarin is a vitamin K antagonist, which inhibits the vitamin K-dependent clotting factors 2, 7, 9, and 10. The problem is the anticoagulant protein C and S are also vitamin K-dependent. In fact, protein C is one of the first factors to diminish when a warfarin regimen is started, due to its short half-life. It's not hard to imagine, then, that when you combine a warfarin-induced deficiency of protein C with a baseline low level in patients with inherited protein C deficiency, you get no protein C. The same can be said about protein S. Though it has a longer half-life, adding on a vitamin K inhibitor is going to kick all of the protein S out of your system. That's a bad thing, because blood clots will spontaneously form in blood vessels, leading to a unique condition called warfarin-induced skin necrosis. For some reason, the occluded blood vessels are limited to the skin, but they lead to tissue necrosis and subsequent extravasation of blood, causing demarcated areas of purpura and necrosis in the skin. This is why heparin is usually started first, before transitioning to a long-term warfarin regimen, dubbed a heparin bridge. Treatment of warfarin-induced skin necrosis, logically enough, involves stopping warfarin, giving protein C, and starting a different anticoagulant until the symptoms resolve. One last and extremely rare complication of protein C or S deficiency is a condition called neonatal purpura fulminans. This condition only occurs in babies who are homozygous for the mutation causing protein C or S deficiency. As a result, affected infants completely lack these anticoagulant proteins. The extreme thrombogenesis caused by complete lack of protein C or S leads to a diffuse arterial and venous thrombosis, DIC, and necrotic hemorrhagic skin lesions in neonates. Much like in warfarin-induced necrosis, this condition is difficult to treat and often fatal. Let's finish up our talk of thrombosis syndromes with a deficiency of yet another natural anticoagulant factor, antithrombin. At Sketchy, thrombin is a thrombivore, making antithrombin a beaver cage. Antithrombin is normally a part of the negative feedback loop in the coagulation cascade, exerting an inhibitory effect on thrombin, as well as factors 9 and 10. In the setting of an inherited antithrombin deficiency, however, that thrombeaver is allowed to roam free and wreak some serious thrombogenic havoc. This is an autosomal dominant mutation, so again, don't forget the dominant domino wall of the POW camp. In the setting of antithrombin deficiency, PT, APTT, and bleeding times will all be normal, because antithrombin only works to regulate clots after they form. Here's a little experiment you can do to narrow down the diagnosis. Give the patient heparin, embodied by a recurring heparin hunter from Sketchy Farm. In any other patient, you'd expect the APTT to get prolonged, which means that heparin is messing with the intrinsic arm of the coagulation cascade, mostly because of action on factors 2, 9, and 10, the tail end of the intrinsic pathway. But where's our usual prolonged PTT woodpecker? Well, in the setting of antithrombin deficiency, heparin has no effect. That's because heparin needs to bind to antithrombin in order to function. So, no antithrombin, no fun for heparin. While inherited antithrombin deficiency is relatively rare, acquired antithrombin deficiency and hypercoagulability can be relatively common in conditions that cause nephrotic syndrome, due to loss of antithrombin in the urine, as well as protein C and S for that matter. Yep, just dumping a bunch of protein in that urine. Right on his face. Patients with antithrombin deficiency, whether inherited or acquired, have a significantly increased risk for blood clots, with most patients having an approximately 15-fold elevated risk of venous thromboembolic events. Think DVT. Antithrombin deficiency has important implications for treatment, though. Since both unfractionated heparin and low molecular weight heparin are essentially useless in these individuals, as these drugs require antithrombin to function. That means anticoagulation for affected patients typically begins with a direct thrombin inhibitor instead. That no intrudin sign is there to remind you of the rudin suffix common to a couple of the direct thrombin inhibitors, including bivalirudin. And that big gator should remind you of the other direct inhibitors that share a gatrin suffix, such as dabigatran. Tolstoy said, "The two most powerful warriors are patience and time." Well, I'm out of both. So let's wrap this up. It's creepy out here anyway. Antiphospholipid syndrome is caused by circulating autoantibodies that interfere with several proteins crucial to regulating coagulation. You have anticardiolipin, which gives you embarrassing results on RPR and VDRL syphilis testing. Lupus anticoagulant, which is a procoagulant, believe it or not, and beta-2 glycoprotein, the most likely to cause antiphospholipid syndrome. While there is a primary form, most antiphospholipid syndromes are secondary and associated with diseases such as rheumatoid arthritis, HIV, and especially systemic lupus erythematosus. Though the antibodies are there, patients usually require a second hit, like smoking, stasis, pregnancy, OCPs, malignancy, estrogen replacement, to actually develop thrombosis. As with other autoimmune diseases, it's more common in women and presents, if it presents, with DVT, recurrent pregnancy loss, and, less commonly, TIA or stroke, or even MI. Patients with antiphospholipid syndrome can also develop non-bacterial thrombotic endocarditis, which is capable of causing both pulmonary and systemic emboli. What else? Let's see here. Deficiencies in vitamins B6, 9, or 12 alter homocysteine metabolism, leading to homocystinemia and an increased risk of thrombus formation. If your blood resembles tree sap, it's not a surprise it will clot more easily. Diseases such as polycythemia, Waldenstrom's macroglobulinemia, and sickle cell disease increase the viscosity of blood, increasing the risk of venous and arterial thrombosis. Watch out for those weird symptoms in hyperviscosity syndromes too, like vision changes, headache, and confusion. Factor V Leiden, the most common inherited hypercoagulability, is caused by an autosomal dominant mutation in factor V, making it immune to protein C. Increased activity of the coagulation cascade increases risk of thrombus formation, but usually requires a second hit, like smoking, OCPs, or pregnancy to actually manifest. Number 2 is the autosomal dominant mutation of prothrombin G20210A, which increases prothrombin production fourfold and increases the risk of thrombosis. Switching gears. Autosomal dominant loss of protein C or S leads to inefficient deactivation of factors 5 and 8, which, get this, increases your risk of thrombosis. No warfarin, please, as starting warfarin without heparin first can cause the aptly named warfarin-induced skin necrosis. In rare homozygous forms, infants develop neonatal purpura fulminans, in which diffuse coagulation is incompatible with life. Last but not least, antithrombin 3 deficiency. Antithrombin 3 usually inhibits factors 9, 10, and what was that other one? Oh yeah, thrombin. You have to be creative with this one, remember, as heparin is ineffective in treatment due to little or no antithrombin 3. In these patients, skip straight to the Rudins, or you'll be futilely waiting forever for their PTT to rise. Boring. Also boring, prison. Guys? Sweet baby J, they left me. Oh, no. The only one who's gonna be up this late is Dave. Hi, Dave.